For MFP, we looked at is ankle equinus a risk factor for Achilles tendinopathy in sports players? Achilles tendinopathy is a degenerative process of the Achilles. The Achilles is formed by the superficial compartment made by the gastrocnemius, soleus, and plantaris merging to integrate and insert into the posterior calcaneus. These fibers which make up the Achilles tendon are spiraled at 90 degrees to aid in the function of its role in providing elasticity. Similarly to a spring, it stores energy to be released during movements such as walking, dancing, and running. The specific degenerative factors for this condition remain unclear, although there is evidence to suggest that the main pathological development of tendinopathy is strongly linked to excessive loading. The tendon may begin to show signs of inflammation of the outer shape or degenerative of the body as a result of activities exerting beyond its physiological limits. Alternatively, this condition may present even when confined within the parameters of function. The presence of micro tears to the tendon changes the uniform structure. This is caused by a varying force contribution of the gastrocnemius and soleus. Imbalances of these forces can cause localized fiber damage due to friction forces. Prevalence of overuse injuries have increased over the last 3 decades. It is shown in one study that the prevalence is just limited to athletes or sports-related activities. Achilles tendinopathy can also be prevalent in individuals that do not participate in physical sports or activities. In a particular study, found that one of the athlete participants that presented with AT, 53% were involved in running sports. Yep. So the equinus is a condition in which the upward bending motion, dorsiflexion, of the ankle joint is limited. A patient with equinus lacks the flexibility to bring the top of the foot towards the front of the leg. Causes and contribution factors for equinus include the congenital contracture or shortening of the Achilles tendon, anterior ankle bone block, posterior ankle contracture, acquired injury to cause scarring of the Achilles tendon or posterior ankle, injury to the ankle that results in an anterior ankle block, posterior ankle contracture. People with equinus develop ways to compensate for their limited ankle motion, which often leads to other foot and leg problems. The most common methods of compensation are flattening of the arch or lifting up the heel early when walking, toe walking, taking steps by bending abnormally at the hip or knee. The Achilles tendon attaches the calf muscles to the heel bone, calcaneus, and is important because it lets you lift your heel when you start to walk. It also helps in walking, running, or standing on tiptoe. Ankle equinus progressively shortens the Achilles tendon, hence resulting in excessive pull by the tendon on the posterior heel during walking or continuous physical activities. This causes inflammation, swelling, and tenderness of the Achilles tendinopathy. Other risk factors that could possibly increase the susceptibility of Achilles tendinopathy in conjunction with equinus are tendon overuse injury due to excessive sporting activities and running, arthritis, minimal supported footwear, high BMI, which puts strain on the body, including Achilles and foot deformities such as hyperpronated foot. Running with hyperpronated foot may cause a whipping and bowstring action on the Achilles tendon, which will result in high eccentric stress applied at the tendon. We used a modified version of the PICO mnemonic. We did not use the PICO, we used population and exposure, then outcome. Does ankle equinus cause Achilles tendinopathy in sports players?
We searched for articles relating to whether ankle equinus is a risk factor for Achilles tendinopathy. Databases we used include Medline, CNL, Cochrane, Web of Science, Google Scholar, and the La Trobe University Library Search, and the American Journal of Sports Medicine website. Terms we used include Achilles tendinopathy and different variations such as Achilles tendonitis, Achilles tendonitis, to make sure we obtain all possible research on the injury. We also used the terms etiology and risk factors to find research on the causes of Achilles tendinopathy. We also used the terms equinus and ankle equinus. We excluded systematic reviews, articles which discussed illnesses such as etiological factors, such as diabetes and hypertension, articles which looked at genetics, age, and weight as etiological factors, papers which discussed treatment for Achilles tendinopathy, articles which observed external etiological factors, and articles which did not observe equinus or limited dorsiflexion as an etiological factor. We included studies which included the occurrence of Achilles tendinopathy in participants with varying levels of flexibility of the ankle joint. This was to determine whether there is a link between decreased dorsiflexion flexibility and ankle tendinopathy, and to compare the results with normal amounts of dorsiflexion and increased flexibility of dorsiflexion. These articles will help us determine whether equinus is a risk factor. The article Intrinsic Risk Factors for the Development of Achilles Tendon Overuse Injury was found through research in the American Journal of Sports Medicine. This prospective study evaluates the risk factors of Achilles tendinopathy in cadet officers taking part in military training. The article The Effect of Foot Structure and Range of Motion on Musculoskeletal Overuse Injuries was found in the bibliography of a systematic review called Lower Limb Biomechanics during running in individuals with Achilles tendinopathy, a systematic review. This prospective study looks at whether the development of musculoskeletal overuse injuries is associated with foot structure.
The studies used are both prospective cohort studies, level 2 on the NHMRC levels of evidence hierarchy. A prospective cohort study, as defined by the NHMRC, is when groups of people, cohorts, are observed at a point in time to be exposed or not to expose to an intervention, or the factor under study, and then are followed prospectively with further outcomes recorded as they happen. An article published in the American Journal of Sports Medicine by Mayhew and colleagues in 2006 involved the design of a prospective cohort study to identify intrinsic risk factors for Achilles tendon overuse injuries. They used a cohort of 69 male Army recruits who volunteered from a population of 191 cadets and followed them over a 6-week training period. Prior to training commencement, each recruit had the strength of their calf muscle evaluated, their range of ankle joint of motion, explosive strength, and the stiffness of their Achilles tendon evaluated. The recruits also completed a medical questionnaire to assess their exercise, medical, and injury histories of the past 2 years, minimizing selection bias. During the 6-week training period, 14.5% sustained a clinically diagnosed Achilles tendon overuse injury. The results of the study did not show statistical significance between ankle dorsiflexion and Achilles tendinopathy. It was identified that increased dorsiflexion range of motion and decreased plantar flexion strength could be intrinsic factors for the development of an Achilles tendon overuse injury. The cutoff value of the plantar strength at 85% sensitivity was 50 torque with a 4.5% specificity. No statistical differences were found between the injured and uninjured recruits in standing broad jump performance, with a p-value of 0.863 and 0.913 for the right and left legs, respectively. The statistical power for the explosive strength measurement was 0.069. The cutoff value of the dorsiflexion range of motion at 85% sensitivity was 9 degrees with a 24.2% specificity. Statistical analysis of the goniometric measurements revealed no significant differences between the groups, however a tendency towards significance with a p-value of 0.076 observed for the right passive dorsiflexion measurement with the knee extended. For this measurement, the injured recruits seemed to have a higher dorsiflexion range of motion in comparison with the uninjured recruits at the start of the military training. The statistical power for the range of motion measurement was 0.314. Thus, participants in these categories were predisposed to an Achilles tendon overuse injury during basic military training, similar to the training that sports players may endure. Mayhew and colleagues did conclude that while a larger study sample may be needed to prove statistical significance, they believe that an increased range of ankle dorsiflexion predisposes an individual to Achilles tendon overuse injuries. Conversely, a prospective cohort study by Kaufman and colleagues investigated the relation between the foot structure and range of motion and lower extremity musculoskeletal overuse injuries among military recruits. Kaufman et al. Found that decreased ankle dorsiflexion is associated with Achilles overuse injuries. The study followed 449 Navy SEAL trainees as its subjects over 2 years. The subjects of this study, similar to those involved in the study by Mayhew and colleagues, were tracked prospectively for injuries throughout training, following baseline measurements of ankle motion, subtalar motion, and the static and dynamic characteristics of the foot arch. Talar calcaneal inversion and eversion were measured using a handheld goniometer. The zero starting position was defined as the positions with the heel aligned with the midline of the tibia and the ankle joint in a gentle dorsiflexion, for example, when the Achilles tendon became taut. 23% of trainees developed Achilles tendinopathy. Subjects with greater than 11.5 degrees dorsiflexion with straight knee were 3.57 times more likely to develop Achilles tendinopathy. Subjects with increased hindfoot inversion were 2.79 times more likely to develop Achilles tendinopathy. A 95% confidence interval identified that the mean population of tight ankle dorsiflexion range of motion led between 1.02 and 12.68, with a risk ratio of 7.9 and a p-value of approximately 0.05. This study aligned with our proposed risk factor finding that decreased ankle dorsiflexion is an intrinsic risk factor for Achilles overuse injury.
As you know, we have been researching the association between limited ankle dorsiflexion and the development of Achilles tendinopathy in athletes. Due to the increasing number of players suffering from lower limb overuse injuries, we were investigating the literature to determine if it would be useful to put in place a screening program to help us prevent injury in those players that display risk factors. We scoured the literature and found 2 articles, both prospective cohort studies, Level 2 on the NHMRC levels of evidence hierarchy that we have used to aid us in making our decision. Using these articles, we have decided not to include a static measurement of ankle dorsiflexion in our players' screenings. Using a modified interpretation guidelines from Van Tilda, Phelan, Bombardier et al., we have found conflicting evidence as to dorsiflexion being a risk factor for Achilles tendinopathy. That is, the studies we have found intrinsic risk factors for development of Achilles tendon overuse injury written by Mayhew and colleagues, the effect of foot structure and range of motion on musculoskeletal overuse injuries written by Kaufman and colleagues had no consistency between their results. In fact, the studies had opposite findings on whether it was increased ankle dorsiflexion or decreased ankle dorsiflexion that was the risk factor for Achilles tendinopathy. Due to the conflicting nature of the literature of this issue, we have decided it would not be advantageous at this time to include a static assessment of ankle dorsiflexion in the screening of players for injury prevention.